Good evening. This is Dr. John Bennett broadcasting from Miami, Florida. Tonight we have another in the series of Parkinsonism educational hangouts with Dr. Abdul Rana, a neurologist from Toronto, Canada, and a world-renowned Parkinsonism educator. Tonight, Dr. Rana is going to be talking about the diagnosis of Parkinsonism, how it's discovered. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
How are you doing tonight?
Fine, thank you. How about you?
Very good. Okay, I'll start off with the first question. What is the main component in the diagnosis of Parkinsonism?
The diagnosis of Parkinson's disease is mainly done by history and physical examination. Sometimes the signs or symptoms could be so subtle that we might have to see a patient twice or even more. There are no particular investigations which can confirm the diagnosis of Parkinson's. Patients have these questions that CT scan or MRI, would it help? So CT scan and MRI are usually normal, and sometimes they may show age-related atrophy, which is the shrinkage of brain. Sometimes fluorodopa PET scanning may show decreased uptake in the striatum, and putamen is more affected than caudate. However, in typical cases, the imaging is not required to make a diagnosis. And if patients have a good response to levodopa, then this is considered to be consistent with the diagnosis of Parkinson's in the presence of other main symptoms.
Okay, what are the clinical features tested? How are the clinical features tested?
The main and the cardinal feature of Parkinson's disease is bradykinesia. And bradykinesia is tested in the upper extremities as well as in the lower extremities. In the upper extremities, you may test bradykinesia by different ways. You can ask them to do fist clenching, like opening and closing the fist repetitively, or do the finger movements like finger tapping. You could also do side-to-side movements of the hands. And in these patients, you would see that they would start normally, but their speed would decrease or their amplitude would decrease. They would fatigue slowly, but you have to give them enough time. And in lower extremities, in the legs, you can test it by the heel tapping. You can ask patients to tap their heel on the ground, and then you can compare both sides. Or you can ask patients toe tapping. They can do toe tapping, and then you can compare. And you would see that on the affected side, their amplitude would decrease or their speed would decrease, and it would be different than the other side, because usually symptoms of Parkinson, they start on one side, or they are more prominent on one side than the other side. Sometimes if their slowness of movements is subtle, you may look at the shoulder shrugging. You may ask patient to shrug shoulder on both sides, and then you can compare one side with the other side. So you would see a subtle difference that one side is slow and the amplitude is less. Beside bradykinesia, you can test rigidity, which is like referred as a stiffness of the muscles. So you can test it by the passive movements at the wrists, at the elbows, and you can also test it in the lower limbs, at the knees. And also, this can be tested at the neck, the axial rigidity. In idiopathic Parkinson's disease, the rigidity in the upper limbs is more than the rigidity in the neck. The neck rigidity is tested by moving the neck like side to side gently, and it's different than the nuchal rigidity, which is tested in meningitis, which is usually by the up and down motion of the neck. So with the rigidity, you would notice the stiffness. The stiffness is usually throughout the range of motion, and with the speed of testing, it does not increase as compared to the spasticity. spasticity, which is a sign of pyramidal lesions like seen in stroke or MS, that increases with the speed, and you can feel a catch at the end of the movement in these patients. So rigidity is different. Sometimes rigidity may be accompanied with cogwheeling, which is like a type of ratchet feeling through the range of motion when you are testing the rigidity. At times, the rigidity may be subtle, and then you may have to reinforce it, like you may have to ask the patient to do some movements on the other side. Like if you're testing the rigidity on the left side, you may ask them to do these type of movements on the right side that reinforces to bring on the rigidity on the other side somehow. In addition, you can test for tremor. The tremor is usually present in more than 2/3 of patients. And the classic tremor is the resting tremor of Parkinson's disease, which is usually a low frequency tremor. And in the beginning, the amplitude may be less. The tremor may just involve sometimes just the index finger, or sometimes the index and thumb, and sometimes it could be a subtle motion of the fingers. And the tremor may be reinforced by asking patients to do mental tasks, like asking them serial sevens, counting from 100 backwards by sevens, or by threes, or maybe saying reciting the months of the year in reverse. And sometimes you can give them some calculations to test. And the tremor usually becomes more prominent as you stress patient. And a very subtle tremor could be made more obvious by these maneuvers. The tremor, as I said, in most cases is supination pronation, which is like side-to-side movement, although it could be subtle. And the amplitude of tremor usually is also very mild, and frequency is low. Low means between 3 to 5 or something like this, up to 7. When the amplitude is very low, frequency could be a little bit more. And when the frequency is low, the amplitude could become more. So this changes as the disease progresses. And patients, by their will, they can stop the tremor of Parkinson's disease if they pay attention. And usually the tremor of Parkinson's disease in the beginning, in most cases, does not have the postural component or the kinetic component, action component. When patients outstretch their arms, they usually don't have the tremor, like this type of tremor, or when they do finger, nose, finger testing, they usually don't have a tremor. But in some cases, the postural or kinetic tremor could be present in the early stages, and it's usually less prominent than a resting tremor, and sometimes there may be no resting tremor. Patients may have a kinetic or action tremor only. And as disease progresses, the tremor, which is initially a resting tremor, it could become more prominent in the action when they are doing finger, nose, finger testing, or when they are out stretching their hands. The one important thing which may help sometimes is latency. Like if they are having a resting tremor and they do have action tremor also. So when you tell them to stretch their arms, so there would be a latency of several seconds before they would start having a action or a postural tremor in case of Parkinson's disease. Whereas if they have essential tremor or other types of action tremor, usually there is no latency. They outstretch the arms and you can see the tremor going very shortly after that. The few other things which can help, that the tremor of Parkinson's disease usually does not affect voice or head. It usually affects the upper extremities. It could affect the lower extremities, but only when patient is sitting. And the tremor should be tested when you are completely relaxed, because sometimes patients who have essential tremor or an action tremor, so if they are sitting and they are not relaxed, they could have a subtle resting tremor as well, which is due to impaired muscle relaxation. So patients should be made to lie down and examine while completely relaxed. When the physician has a doubt or a concern, and that would help to bring the tremor out more easily, and stressing them with a mental task would also help. And then you move on to test the gait of the patient.
Okay, I have a question. Could you show us how a typical Parkinson patient has bradykinesia of the hands? Like, could you show us with your hand motions how a typical Parkinsonism patient looks like with bradykinesia as far as the hand motion?
Right. So when you tell them to open and close their hand, they will start okay, and then slowly they will go slower and slower. Either their amplitude will become less, the speed will become less, or sometimes they would have the arrests. Like when start, they're like this, then they go like this.
Wow, is that pretty diagnostic? I mean, is that in 100% of Parkinsonism patients?
Bradykinesia is usually seen in most patients.
Okay.
You just have to use some of the maneuvers to bring it out. It could be very subtle in some patients, but still with a very vigilant testing, you can detect it.
Okay. Okay. What do you look for when you're testing a typical Parkinsonism patient as far as gait?
Right. The gait testing gives a lot of information, not only for Parkinson's, but about other neurological conditions as well. Now, these things which we discussed, like bradykinesia or rigidity or tremor, now this is in addition to a complete neurological examination. You do all of the examination, like the cranial nerves and speech, higher mental functions, and then motor testing, and in a first time, when you're seeing these patients, the reflexes and checking of the Babinski. And then these are the additional findings which you have to look for: bradykinesia, rigidity, and tremor, to come to a conclusion of Parkinson's disease. So gait gives a lot of information. If you just look at the patient, how they walk, that could give you quite a good idea. And sometime when you're going to the waiting room to take the patient, and when the patients are standing up and walking with you towards your room, so you can be very sure about their diagnosis. So when you look for gait, you ask these patients to stand up from a deep-seated chair. So usually in the office, those people who work with Parkinson's, we have usually not the regular chairs, but a little bit deep-seated chairs, so that we can assess the proximal standing up. So you look at the patient to ask them to stand up, and maybe preferably, if possible, their arms folded. Like you tell them to fold their arms, and then you stand up. So some patients, in the early cases, they would have no problem in standing up, but some patients who have a little bit of moderate stage Parkinson's, they might have to either lean forward, or they may have to make multiple attempts, or they may have to move to the edge of the chair to get up. So that would give you one clue. And then you look at how they start walking. So patients may have start hesitation. By start hesitation, you mean that when they start walking, their feet get somewhat stuck to the ground. They feel that feet are glued to the ground, a sort of freezing. So they might have this start hesitation. So when they overcome this start hesitation and start walking, then you notice their speed of walking. Is their speed of walking normal? And then you look at their stride length. What is their stride length? Is that shorter than normal? And then you look at their base. Is the base wide or narrow? In patients with Parkinson's, usually speed will be slow, base would be narrow, and also their stride length is short. And sometimes this has been referred to as shuffling of gait. They don't lift their feet too much. Their feet are too close, and they go like this. So patients, families would say, it's quite commonly known in public, the shuffling. They would say that, oh, they have been doing shuffling of gait. And then when these patients are walking, you look at the arm swing and the asymmetry of the arm swing. If their arm swing on one side is less than the other side. And then you can look at their posture, at their neck, at their hips, knees, elbows, they would be somewhat flexed. And when they are walking, so you should try to make them go through a doorway, because from your room, you should check their walk in a hallway, and so that you can assess their gait properly. So when they go through the door frame, so some patients who have freezing, so they may have a mild freezing at that stage. They may have difficulty to come out, go through the door frame. They may again feel that their feet are somewhat glued to the ground. And then when they're walking, so you can look at the tremor also. The tremor in the arms on the side, it would become more prominent. Like when they're walking, they are not aware of their tremor, but their hand will go like this. It's hanging on the side when they're walking, but their hand is start like doing that. That would give you a good clue that they have tremor of one side. And then their ability to turn. These patients would make a wide turn. Usually they would turn in in a wide circle, and some patients with a little bit of moderate disease, they might have to make short steps before they could turn, and that's we refer as a turning en bloc. So also, when they're turning, they might freeze at that stage as well. So when they come back, so you can see them sitting in the chair. Some patients would freeze, or some patients would just drop in the chair because of their impaired postural reflexes, which you test with a pull test. It's done usually at the end of the examination of the gait.
So the patients can't smoothly turn. It's very staccato, the turn.
Right.
Okay.
In a wide circle they turn.
Okay. What is this pull test?
In pull test, you check the postural reflexes of the patient. The pull test was introduced in mid 1980s in the Unified Parkinson's Disease Rating Scale, the UPD-RS scale, which we use to rate these patients. And since then, it has become a widely used tool to assess the postural instability of these patients. So you give them a warning. You make them stand up in a space and back towards you, facing the other side. You give them a warning that you will be pulling them backwards, and they should try to stand as firm as they can, but you should stand behind them to avoid them falling. Otherwise, they might fall. Now, this pull test has advantages because it would give you some clue about their posture reflexes. Then you don't need any big space for this. You can test it in even a small examination room, and you don't need much of the equipment for this. And it's a good tool to tell you how is their balance. But about pull test, it has some shortcomings as well. That the exact execution of pull test and scoring, not all the experts agree about its scoring, and then most experts develop their own feeling after working in this field, how to interpret pull test. Also, pull test may not be able to predict fully about the future followers, and there may be lack of obvious correlation between the findings on pull test and postural instability. So when you tell these patients, then they are standing with their feet apart, they are ready, so you give them, you go like 1, 2, 3, and you pull them from the shoulders back. And the patients may have different responses. The patients who have normal postural reflexes, they may keep on standing there, they're firm, they don't move backward. Some patients may take 1 or 2 steps, other patients may take 3 or more steps, and some patients who have impaired postural reflexes, they might not recover without the help. Those patients who have borderline, they can recover unaided, but they may take up to 3 steps. But those patients who can recover, you have to hold them so that they don't fall. And other patients may be very unstable, that when you make them stand up like this, you give them a very little pull and they will just go backwards and fall on you. So you have to support them. And there are some patients in advanced stages, they can't even stand up without the help. they would be just not able to hold onto themselves when they are standing. With respect to the diagnosis, it's as I said before, because there is no specific confirmatory test, so it depends upon history, physical examination, and looking at everything with a parallel history also, so you get a feel by the end of the examination about their diagnosis. So most experts think that if patients have bradykinesia and they have either a resting tremor, a typical tremor, or rigidity with it, in the absence of any other things which could be a confounding factor, and that is quite suggestive of Parkinson's. And if they respond to levodopa, then that helps you to come to a conclusion of the diagnosis of Parkinson's disease, although the final confirmation can be only done by the autopsy in case of Parkinson's disease.
Okay. I was going to ask a question. I forgot what it was. No, that's right. The disequilibrium of a patient in Parkinsonism, is that a muscular disequilibrium or a vertigo type of disequilibrium?
Yeah, yeah. These patients, no, they don't have the vertigo type disequilibrium. No.
Okay.
It is it's
all muscular, huh?
You can call it muscular, or yeah.
Okay.
I don't know what you call it, but it's they have their posture reflexes. They are impaired. They have delayed reaction time. So many things they have, and also with the bradykinesia, when they're walking, there's decreased speed, short stride, narrow base. So all these things add up to cause the postural issues, which may not be impaired in the beginning. Usually in first couple of years, patients have a good balance, and it starts becoming more prominent after a few years of the diagnosis of Parkinson's disease.
Okay. What can mimic Parkinsonism?
That's a very interesting question. It's Parkinson's may seem as a very easy diagnosis, that you got a tremor, you're slow, and that's it. You got Parkinson's. So I'm a student of Parkinson's disease and movement disorder, and I've been studying Parkinson's for so long, and I still get confused. And I'm sure once a person sees, you're seeing 1,000 patients, I'm sure there is a chance that he may overdiagnose some or may underdiagnose some. It's just a human thing. It's not, no one could be 100% perfect. I'm sure in a big practice, it could be difficult at times. And especially it becomes difficult if patients have conditions which could mimic some of the symptoms of Parkinson's, such as essential tremor. The essential tremor is a different type of condition, and it's a postural and action tremor affecting the upper extremities in the beginning, although it may involve other parts of the body. And it's a tremor which mostly is complained that patients have trouble writing, or holding cups of liquids, or eating with spoon and fork. And usually they have a family history, and there is a long-standing history. It's bimodal in presentation, like usually in 50s, but it could come in 20s in some cases. And it's usually bilateral, although it could be asymmetrical. So this becomes a problem when patients have long-standing history of essential tremor. So if patients are elderly, so they got arthritis, they have age factors, so they could be slow due to those problems. And then because essential tremor becomes severe, so it could have a resting component. So you feel very confused that they got some resting tremor, they got some slowness. So slowness, resting tremor, and they could have cogwheeling. A slight cogwheeling at elbows is common in elderly individuals. So it could be difficult to detect in those cases. So you may have to see these patients a few times, and some experts in the past times, they used to give patients levodopa and see if they would respond. So this becomes a problem. It could very well mimic, and people could be overdiagnosed, or sometime it happens that patient had essential tremor anyway, like they had essential tremor, and they got Parkinson's like any other person can get Parkinson's, so they fall into that group. So so unfortunately they had essential tremor, now they are getting Parkinson's, and now you're confused. Is it only Parkinson's? Is it essential tremor plus Parkinson's? Or is it essential tremor in the advanced stage, which is causing the resting tremor and some cogwheeling and those things? So it could be a challenge in some cases. Other conditions which may mimic are atypical Parkinsonism, such as progressive supranuclear palsy. These patients have trouble with their balance in the beginning. They can't hold their balance. There is history of falls in the beginning. And they also have issues with cognition. When you look at them, they have symmetrical findings on both sides. They could have trouble with speech and swallowing starting in the beginning of the disease. And it's very important to differentiate this as well. And in the beginning, for first year or so, it may be difficult when they don't have any typical symptoms. You may be confused whether it is Parkinson's, or then it may evolve further features and you can be comfortable saying that this is progressive supranuclear palsy. Multiple system atrophy is another thing. These patients are presenting with lightheadedness. They have partial hypotension. They may have trouble with their speech. They may have difficulty with balance and somewhat slow. And they have a sexual dysfunction. They might have gastrointestinal dysfunction, diarrhea, alternating with constipation. So that could be a challenge as well. And there's another condition called corticobasal degeneration, which is even more difficult to differentiate because that's very asymmetrical. In cases of progressive supranuclear palsy or multiple system atrophy, patients have findings on both sides of the body, so it's symmetrical. But in case of corticobasal degeneration, the symptoms are very much marked on one side of the body. One arm is quite stiff. It could be spastic as well as rigid and in a dystonic posture. And patients may not swing that arm. So you get confused that, oh, wow, this is one-sided. And it's quite asymmetrical. They're slow. So that could also be a challenge to differentiate, especially early in the course of Parkinson. Some patients have vascular Parkinsonism. So they could have ischemic disease, which is causing mostly the effect on their lower body, so their gait and balance is affected. But when you test their finger tapping or opening and closing of hands, they could be quite good and they're symmetrical. So vascular Parkinsonism. Patients with vascular Parkinsonism may have more freezing, and it's very much resistant to treat with levodopa. Drug-induced Parkinsonism is another condition. If patients have been on antipsychotics, they get bilateral disease, they have multiple types of tremor, resting tremor, and postural and kinetic tremor, that could sometimes be mimicked. And then Lewy body dementia. These patients may have subtle focal signs, such as a mild tremor or rigidity, but they usually have hallucinations, visual hallucinations, fluctuation in cognition, episodes of confusion and disorientation, starting in the beginning of the disease. Now, when you see them, you are not sure when these problems started because history may not be clear always. So that's another problem. And normal pressure hydrocephalus, sometimes it's a bit dubious diagnosis. So it's overcalled sometimes. There is a slight enlargement of ventricles in patients. We have seen patients who were shunted and they develop Parkinsonism afterwards. So they likely had Parkinson's disease, very mild presentation, but they had slight atrophy and some ventricular enlargement, just incidental, and they got the shunt placed. So normal pressure hydrocephalus usually is a triad of cognitive difficulties, incontinence, and gait ataxia. Their gait is like a magnetic gait apraxia, but all these three components, they don't have to be at the same time, so which makes things difficult. And then Wilson disease remains another thing which could be confused early on. But patients with Wilson are usually younger. They have psychiatric components, and they have multiple movements. Like they have dystonia, they have typical facial appearance, and they could have other things like Kasher-Fleischer rings, and then some metabolic abnormalities. So as I said in the beginning, it could seem a straightforward diagnosis, but it's not usually straightforward in all cases.
Right. So essentially a clinical diagnosis.
Right. It is a clinical diagnosis, and we just conclude when patients respond to levodopa and their symptoms improve. So that gives us reassurance that yes, our diagnosis is correct.
Okay, very good. That's about it for the diagnosis of Parkinsonism. Anything else to add, Dr. Rana?
What I learned, my personal experience, when you are young, you are energetic, enthusiastic, and overconfident sometimes. I think if you have a little bit of uncertainty, you should wait. You should reassess patient the second time, and if you're still not sure, you can see them third time, as long as their disease is not very much progressive or not causing trouble with their activities of daily life. I think taking time to reassure, assessing them a few times till you reach a very much certainty that you're correct is good. And one should not rush in the beginning if patients don't have typical symptoms, like if they don't have a tremor and you are not sure. So I think patients should be reassessed.
Okay, very good. That brings us to the close of a hangout on Parkinsonism education regarding diagnosis of Parkinsonism. The show can be seen on Parkinsonism.tv anytime, 24 hours a day. Thank you, Dr. Rana.
Thank you, Dr. Bennett.
Okay, stay tuned for the next one. Thank you.
Of course.